We're going to have these presentations of select findings from a study called HCR number 91 on 2020 on health services for persons incarcerated in state correctional facilities. Representative
Yes.
Landry, would you tell us about yours, please?
Yes, thank you for letting us present briefly to you this morning. This was an HCR that we passed last year in the middle of COVID, and part of the impetus for it was we saw how quickly and how awful COVID spread in prisons and correctional facilities in the state, affecting not just the inmates, but wardens, employees, so many people. And so what we did was put together a really robust working group to look at healthcare in prisons. And I assisted the group in getting documents from DOC. We had several boxes worth of documents for them to look through. They spent a lot of time on this report looking at it, and they would appreciate if you would give them a few minutes of your time so that they can present their findings to you.
They can, and you will need to put up, I guess, a green card and sign and do all that when you finish, okay?
Okay.
All right, introduce yourself and what you do.
Yeah, we do have some slides. I'm not sure if I got to
I think
click mirroring or
sent to
something
Christy.
of that. Christy, if I could. Oh, that's Rob. Thank you. Good afternoon, Mr. Chair, members of the committee. My name is Bruce Reilly. I'm the Deputy Director of Voice of the Experience, known as VOTE. And we're grateful of Representative Landry for putting this together for us. One of the things that this was rooted out of was also the many complaints about how the doctors inside of the prison are on suspended licenses. And so when we were moving forward that issue, one thing that we realized was there was a gross lack of awareness about healthcare in prisons and jails generally. And so this step, along with the COVID crisis, was what we were trying to then drill down and figure out how it is that we can express to you what's going on with the healthcare delivery system. So I have two amazing colleagues here with me that will introduce themselves, one from the LSU School of Public Health, another from Loyola College of Law. And we tried to really drill this thing down to some specific areas to talk about. And we combed not just records from the Department of Corrections, but also from the Department of Health, and also from court records, including the Lewis v. Kane lawsuit that you may be aware of about healthcare in Angola, which recently ruled that their healthcare system is unconstitutional. So they're still in the remedy phase of trying to figure out how they're going to move forward. And so we've got some very basic sections that I'm going to turn it over to my colleagues, Ashley Wennerstrom and Andrea Armstrong.
Good morning, everyone. My name is Ashley Wennerstrom. I'm an associate professor at LSU Health Sciences Center in New Orleans. So I just want to start by giving a brief overview and some grounding. And when we're talking about the healthcare system, we are talking about 8 state prisons across our fine state that are required to care for about 16,000 people. And just want to highlight that national research indicates that people who are incarcerated are generally much sicker than the general population. And we have just a few numbers here to give you a sense of what we are talking about when we're looking at our population here in Louisiana. At Allen Correctional Center, about 50% of people there are diagnosed with hypertension. At Dixon Correctional Institute, there is an in-house dialysis unit, so that's where all people who have dialysis in the state who are incarcerated go. And about 40% of the folks there qualify for a medical diet. At Raymond Laborde, we saw 32 medical-related deaths in the years of 2015 to 2019. One of those was a 24-year-old man who died of an asthma attack. We saw 11 deaths related to heart attacks and 9 related to cancer. At Louisiana Correctional Institute for Women, 50%, fully half of incarcerated women had a prescription for mental health. Just to provide a little bit of context for that, we expect to see about 5% of the general population would have some sort of mental health diagnosis in any given year. So that's quite a bit. At Louisiana State Penitentiary, better known as Angola, in our records, we found that there were about 8,000 requests for specialty visits within a given year, and only about half of those were followed up upon. Then we get into At Rayburn Correctional Center, where 90% of incarcerated men receive some sort of prescription medication. At David Wade, about 30% of men have some sort of serious mental health disorder. Those include things like post-traumatic stress, anxiety, schizophrenia. And then finally, at Elaine Hunt Correctional Center, 17% of the incarcerated population has been diagnosed with hepatitis C. And again, for some context, we would expect a prevalence of about 1% in the general population. So now I'm going to turn it over to Professor Armstrong to talk a little bit more about the access to healthcare situation in these prison
Good
facilities.
morning. My name is Andrea Armstrong. I'm a professor of law at Loyola University New Orleans College of Law. And what I wanted to convey to you all today is that there are challenges for how the Department of Public Safety and Corrections provides health care to people who are incarcerated. Within this context, people can't go and seek the care that they think they need. They are fully 100% reliant on the department to provide access to the health care in light of the very significant needs that my colleague, Professor Wennerstrom, discussed with you. And so we have a couple of categories. I'm not going to go through each in depth, but I do want to say that, these 5 bullet points that you're seeing on your screen, medical copays, preventative medical health care, dental care, sick call process, and potential disciplinary charges may act as barriers to people accessing the care that they need. And so with medical copays, it is standard in Louisiana for a $3 copay for a sick call visit, $2 for a prescription visit, and $6 for what's considered to be an emergency sick call request. But keep in mind that our incentive wages that are available to people who are incarcerated are, begin at 2 cents an hour. And so for people who are earning 2 cents an hour, that $3 copay, which may be reasonable to us with salaries and access to other resources, that $3 copay becomes a $1,000 copay simply to access your health care. Now, that health care is not denied if you are unable to pay, but it does result in medical debt on your account. And so I think that those numbers might be helpful. When we think about preventative medical care, I know many of us are, at least my mother reminds me often, have you done your wellness exam, right? You are age such and such. You should be going to see your doctor. But in our prisons, what we know is that wellness exams are only available for people who are 50 years or older. And we know that best practices indicate that we should be doing wellness exams, including specialized testing, beginning for some conditions at age 40. Dental care is another issue, and this is an issue nationwide as well as in Louisiana, where the primary form of dental care consists of extractions of your teeth, right? And so if you do not have access to cleanings or preventative care, then what you're dealing with is a population that is gradually losing their teeth, unable to provide basic nutrients for themselves. Last, there was significant disparities in terms of potential disciplinary charges. On the one hand, what Department of Corrections will say is that we don't enforce charges of malingering for people who file a sick call request, i.e. a request to see a doctor, and then a healthcare staff person finds that request was not appropriate. And so what they're doing is involving healthcare staff in a disciplinary process, and people may be hesitant. Even though DOC says that it is not enforcing this, we did see evidence of information given to incarcerated people that this was in fact still a policy. On healthcare delivery, which is the next category that you'll see described in the report, we note several different areas of concern, beginning first with patients in segregation, right? So people who are in segregation, and that can be for a variety of reasons. That can be disciplinary, that can be medical, that can be for suicide watch, or protective custody, for example. Their access to care is difficult because it is cell side primarily, a not private setting. And there's indications from internal audits that certain required checks are not being performed for people who are housed in those conditions. Chronic and specialty care, again, was another issue of concern. And there, our colleague mentioned the orders that were given by doctors who are employed by DOC are ordering specialty consults for people in their care. And those specialty consults are not being completed. None of the facilities completed 100% of the orders made by their own doctors. And in fact, at Allen, it's only 50%. Behavioral health continues to be a problem in terms of psychiatric availability and times across facilities. And really, clinic care and emergency care we can think of similarly because they are designed to treat episodes, not necessarily care for health. Last, medication delivery is also proving problematic with different policies across different facilities, and that gets to some of our recommendations, which you'll see presented later after the next section by Professor Wennerstrom.
All right, and now I'm just going to highlight a couple of our findings related to healthcare administration. So one is related to release planning. The Department of Corrections has worked very effectively with the Louisiana Department of Health, in recent years on several different programs. One in particular is focused on ensuring that people who are living with HIV have access to medication upon release. Recently, the department has started working closely, again, with the Department of Health on the hepatitis C elimination plan and has successfully administered medication to treat hepatitis C for almost 400 patients within a pretty short amount of time. And then we also know that there is an effective program going on now that's focused on enrolling people in Medicaid upon release. So those are some bright spots. Some of the other issues that we'd like to highlight, and Bruce mentioned this at the beginning, but this is the issue of license status for healthcare providers. We requested information about the license status of all of the healthcare providers that are currently operating in Department of Corrections facilities. We did not get that information. However, we know that the Louisiana Board of Medical Examiners does issue institutional permits that are allowed for people who have a restricted license, and they may be used in correctional settings. So that certainly raises some concern about the qualifications of the healthcare providers and our DPSC facilities. As far as medical records go, we have heard anecdotally that there are a few prisons that have recently started to use medical records, but in the rest of cases, all medical records are paper-based. This creates complication. Obviously, just dealing with large amounts of paper is complicated in and of itself. I'm sure when most of us go to the doctor, we see that they've moved to medical records. One of the biggest challenges is when people are going to outside healthcare facilities. If they have some condition that's not able to be treated on site, they go to outside hospitals. And we talked to several outside healthcare providers who highlighted how difficult it is to treat patients when they don't have any background information on the condition of the people that they're treating, and then they send them back to the facilities with various recommendations about follow-up care, about medication, and there's absolutely no way to track down whether people are getting the care that they have recommended. So this is certainly a complication. We also found a lot of staffing vacancies. So for example, there was one facility that had 2 nursing vacancies for over a year, which is certainly problematic, and a lot of the internal audits that we reviewed demonstrated that this was consistent, a lot of staffing vacancies and high rates of turnover. We also noted that prisons were spending less than their authorized budget for professional services. And these types of services are things like dentistry, specialized counseling, psychiatry, radiology, and the budgets are continuing to drop in that area, which is very interesting because at the same time we're seeing an overall increase in medical expenditures for prisons. And in fact, we saw about a $15 million increase between fiscal year 19 and fiscal year 20.
If I can interrupt, I have some questions, and they're going to learn a lot more if they ask you things. And
Absolutely.
yes, Representative Eccles, you have a question.
Mr. Chairman, I have one question, 13 parts and 4 subsections. So. Actually, I'm a little bit familiar with this issue and some of the challenges you face in the penal system and the halfway system. And so I know that there's some fixes that are out there, and there's probably some model programs in other states that they've embraced. First, have you guys worked with CMS and the Department of Health on any waiver-based programs that could enhance delivery of services through our current Medicaid benefit?
Yeah, so I've only looked at that issue in relationship to Medicaid billing, right? And so, for example, someone who's incarcerated is not eligible for any sort of Medicaid reimbursement, however, if they're released. And so there have been attempts to receive certain types of limited waivers for people who are incarcerated. That has been more successful in certain states, and I don't believe Louisiana has actually tried to do that, but they
So
are very
New York,
limited.
I think, has been one that's done it, and there's several East Coast states that I think have done this.
Yes, in very limited proportions, though, and primarily you're looking at jail populations for those people, not necessarily for people who are doing conviction sentences.
And there's another challenge in this space with providers. One, they will take the prisoner to a physical clinic, and that in some cases can endanger populations depending on the severity of the crime that was committed. So I know that's a big challenge, getting patients to specific specialists. So you really want them to come into the prison system itself to deliver a lot of those services, again, creating another challenge for individuals. Halfway house individuals that are transitioning out of the jail system into a working relationship but still being somewhat confined. Many of those individuals do build up dollars in their account. It's not the rate that you're talking about, it's a higher rate. But in many cases, if they're forced to go to a hospital, they're forced to pay billed charges for their service lines. So it could be blood work, it could be a heart monitor, and instead of paying, what a traditional insurance company would pay, they may pay $500 or $1,000 for blood work. And so I think that's an unfair practice, and it's something that we need to work on. And so if there was a waiver pathway for you guys to work on with CMS to look at both those that are incarcerated as well as those that are transitioning out, I think that would be very, very beneficial for our system. And working on some of these, cash pay costs, again, that's unfair for individuals. So I agree with your process and your path.
I would just suggest that medical furlough and medical parole are also viable alternatives for shifting the cost to Medicaid, right? So if someone is basically that doesn't end their sentence per se, but they're simply housed outside because of significant medical needs, those needs could then be paid for by Medicaid.
And one last contention, and I know my colleagues know because I say this a lot, if you stop medical care or delay medical care, the costs become far more absorbent the further you go down the line. So having access to quality care on the front side, first day, second day, third day, is far more pays off than waiting a year or 2 years. So thank you for your efforts, and I think we have some common ground on some of these points.
Thank you.
Thank you, Representative. Representative Presley?
Yeah, I just wanted to follow up on a couple of y'all's statements. One, and I'm sorry, I didn't catch your name.
Ashley Wennerstrom.
Miss Ashley, if I believe you said that you couldn't get the data on the providers. Why not?
That's a great question.
Was that from the department we couldn't get it, or was that from?
I can say that it was a top line request in our records request that Representative Landry submitted to them, and they were very forthcoming in many ways, and they just bypassed that one. We do know that from if one reads the decision in Lewis v. Kane from Justice Shelley Dick of the Middle District, he or she writes explicitly in there that the department doesn't even keep that. Whether that's accurate or not, that was what their findings were. And so their thinking in that decision was, if you don't keep the data, how do we know if you're keeping up to standards? So it's just the guesswork.
Yeah, that's interesting. I think that's something that I'll certainly get with Representative Landry and see if we can find that data. That seems odd to me that we don't have that. And then I was just perusing the handout that you sent, and on page 10 it says only one prison provides free and contemporaneous access to over-the-counter medications such as Tylenol. Which one?
So that would be Wade.
Okay.
So Wade does have Tylenol over-the-counter types of medications located in a key room, which is available then for the guards to provide upon request. Every other facility, it was listed as something that could be purchased in the canteen or could be received through a sick call visit plus a prescription, which is then $5 copay. Translate that into actual incentive wages.
Thank you. I appreciate it.
Representative Hughes?
Thank you, Mr. Chairman. First, Representative Landry, thank you for following the initial resolution and for the follow-up in this presentation, and thanks to each of you. Really quickly, one thing that really stood out, these paper records. That's problematic on so many levels. Not only while these citizens are incarcerated, but to ensure continuance of care when they return. Are other states doing this electronically, and why are we still in the Stone Age?
I personally don't have a sense of what other states are doing. Why we're in the Stone Age, I guess we could all have our own guesses on that. But in conversations with DOC just recently, they were very optimistic that they could get to electronic records by the end of the year. I think, as Ashley mentioned, I think a few of the prisons are already there.
Okay.
And so I believe from their perspective, it was a budget issue.
Yeah.
And so, it's a fiscal session, so give them some money, I guess.
Yeah, I mean, look, I'm glad you raised that issue. We passed electronic medical records well over a decade ago, and we can always make excuses about money. We find money for what we want to find money for, but that's just a huge problem. And so thank you all for highlighting it, and thank you for your work.
Thank you, Representative. Representative Cox.
I heard the same thing. I mean, records, they keep paper records, right? And they would not let you have access to them. Did I hear you say that?
Well, we didn't request individual medical records for patients because of patient privacy. But what I will say is that these records are often voluminous, and through internal audits conducted by DOC themselves, they noted multiple continuing problems with the filing of medical records, right? Such that a person's lab results would be ordered, but the actual piece of paper with the lab results wasn't included in the medical record, but was instead found somewhere else, or even if it was found. And so, these records are very difficult to maintain. Plus, you've also got people who are moving between facilities, right? So we have not only the 8 operating state prisons, but we also have over 130 other facilities within the state. And a person could be, doing part of their time in Tangipahoa Parish Jail versus also doing a part of their time at Hunt. And so just thinking about how people move.
Yeah,
within
they
the
move.
system.
So you're saying the records do they record? You may not get all your records, what you're saying.
Correct, because different prisons have different policies on what they send with a person. So there is one prison that will only send a medical summary, but not the actual record. There is another facility which has an entire elaborate procedure about a red box, and everything goes in the red box with the person. And so it's going to depend which prison you're at, whether your health records actually get sent to the next place you're going to go.
And who has electronic records? I heard you say there was a couple of.
Natalie the board was telling me the other day, and I don't want to misquote what she said. She did, I think, mention 3 facilities, and I can't remember exactly which 3 they are. So we could follow up and get you that information.
Yeah, I'd like to know. And the other thing was the medicine. Were you saying that medicines, they don't always get the medicines that they should? Or I didn't really understand that.
Well, there's a nexus between security and healthcare in prison, obviously.
Right, I agree. I understand.
And at times healthcare decisions are being overseen by security, and we saw that very clearly in the Angola medical case, and that being a problem. And so there are people who are getting follow-up care from specialists that doesn't get followed up. And it could be a paper records issue, it could be a decision issue, it could be a formulary issue. I'm sure there's a lot of reasons.
What happens when they have to take, pain medication? How do they keep the access to that? Do they get it, or is it given by the guards, by somebody?
So there's a couple of different ways this works out. If it is a prescription medication,
Right.
Some prisons, and again, it's not uniform across prisons, have different keep-on-person policies for not necessarily for pain management, but kind of your daily types of medicines,
daily
right?
medicine,
Because it's a
pain
narcotic,
medicine,
right? So when we're thinking about pain management meds, those would not be keep-on-person generally.
Yeah, I understand.
And those would be then dispensed. And so if they are in certain parts of certain prisons, they may have pill call 3 times a day where they actually go to the formulary, it is dispensed, they take it there, and then go back to cell. People who are in segregation or working cell blocks, It is different. So there is even a policy in one prison that says if you're not up at 5 a.m. when pill call happens, it's not our responsibility to wake you or notify you that it is there. It is your responsibility to be at your cell front doors, right? So with no notice. And so, there can be a bunch of different problems in how people actually get the medicine that they are prescribed to take.
But you also, but they are able to get medication. I mean, they get the medication though, right? I mean, in most cases, I guess.
In most cases, right? But there are also, I think medication comes up in several different ways. For example, in one of the audits, they found clearly expired insulin medication, right? And so are they getting the medication that is fully effective? Right? And then we could also think about whether they may miss pill call because of work duty or what have you, or whether they are cell side, or we know a significant portion, and this comes from a different study, a significant proportion of people who are in segregation have serious mental illness, including schizophrenia. And so their own mental illness may, for example, be a barrier to them getting and keeping taking their medication.
Yeah, but would that not be, they don't diagnose that so that would be taken care of? Because if you don't diagnose that, then you create an additional problem with schizophrenia and people with mental difficulties and stuff.
There was at least one finding in an internal audit by the Department of Corrections that a person who was diagnosed as schizophrenic in their treatment plan said their mental health diagnosis, it was unclear or there was no diagnosis listed. And so even where you have a diagnosis, the treatment plan may not accurately reflect the type of dosages and treatment that the person needs to receive on a daily basis.
So there is there's some discrepancies here. Thank you for, this research. I mean, wow, you did it opened my eyes about some things. Thank you, Mr. Chairman.
Thank you, Representative Cox. Representative Marverdane.
Thank you, Mr. Chair. I want to thank you all for. I'm right here. How you doing? Looking around. Who's talking to me?
I was waiting for the little yellow circle. I'm so used to Zoom, to tell me who's speaking.
We're live and clear. I want to thank Rep. Landry, and I want to thank you all for your time. I'm more concerned with the mental illness with women because in most instances, women may be incarcerated, but it's for a short term. And then most of them are mothers and how they deal with that when they get out. So what are the challenges with women in the mental health? Because we've got to find a way to get them some treatment and get them treatment when they get out.
Well, I mean, one of the really huge issues right now with women incarcerated in Louisiana is, I think, as most people know, there was a flood at the main women's facility years ago. I want to say about 5 years ago now, 2016. Yeah. And so that meant that they had to find other places for people to be. And so eventually they've got two sort of main facilities. One is they opened up part of Hunt, which was a men's facility, to become partially women's. And then they also reopened Jetson, which had been closed down previously for environmental problems. So I don't know if they've remediated that or not, but that became the two main spots. But then I want to say they're in about 30 or so other places, 3 women here, 5 women there, 2 women there, around the state. And for some women that may be a positive, maybe they're close to the end of their sentence and maybe they live in that parish, but I'm sure for a lot of people it's just a space to be. And so if you're in a place where it's not built to have that additional women's medical piece, or for let's say a mental health group or something, you don't have the critical mass, then it's just you just have to try to survive it till you're released. And so there is a group of women who are doing extended times, but as you know, there are many women are doing shorter periods.
That need some help.
But then if you're not able to break that cycle, of course, you're just gonna you're gonna keep on coming into your trauma, and you're gonna keep on finding bad things in your life that lead you back to prison.
Okay, that's yes, ma'am. Go ahead.
2/3 of women serving state sentences are serving them in a local jail. Right? This report only covers the 8 state-managed prisons. It does not cover the over 130 facilities across the state that are operated both by private operators, halfway houses, as well as local sheriffs. And so what that means is 2/3 of the women that are serving their sentences are serving it usually as a smaller cohort. So it's not just mental health, it is physical health as well that is implicated. A local jail is unlikely to conclude a long-term contract with OBGYN in the same way that Hunt and Jetson would for those women.
And so those young ladies who are in the small parish facilities are probably not receiving the care that they need to, and that's another issue because most of them are mothers or in that stage where they can be mothers.
Absolutely. 80% surveys show that 80% of women who are incarcerated are mothers.
Okay. Thank you, Rep. Landry. I want to work with you. I wish we can find a way that we had a crystal ball to provide resources, but I know it's a challenge. But I'll work with Rep. Landry. I know she's passionate about that, but thank you for being here.
Thank you, Representative. Representative Eccles again.
Just one comment. All your problems are going to be solved on July 1, 2020 when operability standards are implemented. All the MCOs will have to work to share data through the cloud via CMS, and then all those records will be out there. So just wanted to let you know the federal government's coming in and going to take care of everything for us.
Don't believe that. And everybody lived happily ever after. Okay, Representative McMahon.
Yes, whoever wants to answer this can, but I want to know a little bit about preventative health and how that's handled in the 8 facilities that you're talking about across the state. Are we using nurse practitioners and physicians, I guess, also? I know some of the things y'all are talking about, the same things we deal with in rural Louisiana, the lack of nursing. I think, even dental health is something that's so important, especially in incarcerated facilities like this to take care of, because so many things manifest out of that. I think we need to focus on trying to put some dollars to the front end to prevent some of these issues and the mental health issues too. But just give me an overview of how one facility would work, and say I'm a little familiar with David Wade because I've been there providing some services for them in the last 30 years, but they probably have 1,000 inmates. How many doctor or nurse practitioner visits are they seeing a day on say 1,000 facility?
So at Wade in specific, they do have a nurse practitioner. You're right that many of the concerns that you see in kind of rural healthcare, we also see in prisons, which also happen to be located in primarily rural areas. So there, they will often have a doctor who is by contract as supervisor there for a limited portion of the week, but the primary care is provided by a nurse practitioner as well as a series of nursing assistants. When somebody is at Wade, they have likely already gone through intake. So intake is a process that DOC has centralized. We see most of that coming through Hunt, and that is where they will have their fullest amount of a kind of physical exam as they come into the system. Following that, though, the only process that is available in Wade is a sick call visit, meaning I have a particular problem that I need to be addressed. And that problem is not necessarily carried forward from one sick call visit to the next, right? So you might have varying symptoms of a longer term disease, but instead what they're treating is that episodic symptom, not necessarily the broader disease, which results in some of the interviews that Dr. Wennerstrom conducted where healthcare professionals agreed that they were seeing people presenting with later stage diseases which could have been more cheaply and more effectively treated earlier.
Well, I agree. I think, there should be some preventative health measures put in place where the inmates are seen on some type of regular basis just for a checkup. That makes too much sense, to be put into place. But thank y'all for your work, and Representative Landry for bringing this to our, and kind of shining a light on some of the problems we have around the state with this. Thank y'all.
Thank you. Representative Johnson.
Hey, thank you, Chairman. Landry, thank you for bringing this study for this bill. My question is more on the mental health aspect. So when a prison have an episode, then they get the help they need. But before that, week by week or month by month counseling, they don't receive that.
So our understanding is that the treatment plans are primarily medication related, that both because of physical space issues as well as staffing, they don't necessarily have the spaces for the types of therapy that we see out in the free world in terms of group therapy, et cetera. Oh, and certainly not with the frequency that we would see that out here as well.
So, like in most public schools, you'll see like a nurse on site, or you'll see one counselor on site. So prisons don't have that one person that works on site.
It varies from facility to facility. So some facilities have really high caseloads, but only have a psychiatrist who's on site 2 days a week. That doesn't necessarily speak to the other types of therapeutic mental health counselors. There has been an issue, I believe, at Wade as well as another prison where the mental health counselors were not actually credentialed and licensed to provide those types of services either.
And through in previous testimonies, we learned that because of the state of Louisiana, there's not a lot of mental health facilities, and so our jails are now housing some of these people who should not probably even be in jail, but should probably be in a mental health clinic. And so that's why I was asking, I'm more focused on the mental health. And again, Representative Landry, thank you for this bill.
Thank you, Representative Johnson. Representative Cox, another question.
Well, you talked about the program of releasing people who are sick and how it saved money for the state. At what level do they do that? Because I have a friend that's at the state penitentiary, and he's been there most of his, I don't know, he served 38, 39 years there. He's had brain surgery, he has other things. To what point do you go on this release? Can you be allowed to go on this release program?
So, I mean, there's multiple ways, as you know, Rep. Cox, to try to get some folks out on that back end. We have geriatric parole for people who,
But they're almost dead, though.
Exactly. And there's some exclusions. There's medical parole, and then there's medical furlough. Medical furlough is open to everybody. As you can guess, people
But the furlough allows you to go home?
No, so the furlough, you have to go to one particular facility,
right?
Which apparently it doesn't have a great reputation amongst the people who might be seeking medical help. And so it may not be an upgrade for some people, at least from their point of view. And so there's room and it also needs to be initiated by the internal prison doctors. And so we don't know if they're making enough, if they're filing enough things to help that process go. So there are some things that maybe we could work on around medical furlough and medical parole in this body to maybe make it so that it works a little bit smoother. I think there's, from what I understand, there's a few too many barriers happening there, and so not enough people are able to access that.
Okay, thank you.
If I would add
Thank you.
Sorry.
Thank you. Representative Moore has a question.
No, I don't have a question. I just want to make a comment like the others. Representative Landry, thank you for this, and thank you all for giving us this information. It is information that I hope that we will move forward and not just let it sit. So again, thank you.
Thank you, Representative Moore. Representative Landry, if you'd come back up, please. And I would say for the members, this isn't the bill. We're not going to vote on this. It's already happened.
Mm-hmm.
She called and asked, could she report this to the committee? I took it on myself to think that the committee would want to hear this.
Mm-hmm.
Obviously, they do, because nearly everyone's asked a question about it. We do appreciate what you did, and it ran a little longer than I had hoped.
Me too.
But that was my fault. I could have stopped it or slowed it down. But I do appreciate the information and your work on this. And do you have a closing comment you'd like to make?
I'm also, it's very heartwarming, the compassionate questions and the interest shown by the entire committee. I think we have a good group to introduce some really substantive legislation last year. And look, sometimes there's good surprises in committee. So I thank y'all for your interest and for your time.